Good evening, everyone, and welcome to this webinar on next generation and surgical specimen imaging with future AI enhancements. This is sponsored by Perimeter Medical Imaging. I'm Hank Schmidt from New York, and I'm going to be joined this evening by Dr. Beth DuPree and Dr. Alastair Thompson, who will also be part of the presentation. This is our agenda for the webinar. We're going to review intraoperative specimen imaging and the role of OCT. That'll be followed by a discussion of OCT, its use in the operating room. Dr. DuPree will have some case reviews. And then we'll talk about applying artificial intelligence to OCT specimen imaging. And then we'll wrap it up with a question and answer session. So we're going to begin by talking a little bit about intraoperative specimen imaging and the role of OCT. What is the current standard of care in specimen imaging? Most of us are familiar with using X-ray to look at surgical specimens in breast surgery. Many surgeons also use ultrasound imaging of individual specimens at the time of lumpectomy. In this slide, we can see in the first figure on the left, initially specimen mammography was done in radiology departments. This required surgeons to wait a significant amount of time as the specimen was transported. We now fairly commonly see specimen radiography in the operating room, shown in the middle figure, which helps us verify that the clip is in the specimen. We also recommend orthogonal specimen radiography, namely taking two views separated by a 90-degree rotation, so that we can see all 6 potential images if we modify this or model the specimen as a cube. In this slide, we see current specimen imaging technology with ultrasound. Some surgeons use ultrasound to image the specimen at the time of lumpectomy. On the left is an example of a breast mass with benign features. You can see relatively smooth borders and this round area of signal loss. The image on the right, however, is an image of a basal-like breast cancer, very typical of malignancy appearance under ultrasound with these really irregular, abnormal margins, reminiscent of spiculations on mammography. We're going to talk briefly about the benefits and limitations of our current technology. The specimen imaging with ultrasound and mammogram provides a surgeon with immediate image-based confirmation that the targeted abnormality was removed. We gain macroscopic view of lesion location and calcifications seen on specimen radiography, and it helps the surgeon ensure that all wires, clips, and seeds have been safely removed. Consider the limitations. Resolution is too low to identify microscopic disease at the margins, either invasive and particularly Dcis. There's a high false positive and false negative result. A recent study showed intraoperative specimen radiography yielding a sensitivity of 41% and specificity of 78% with 2D imaging, and sensitivity of 47% and specificity 75% with 3D imaging for positive margins. Likewise, incorrect results obviously can lead to disease being left behind or excision of unnecessary tissue and resulting potential for need for additional surgery. So to address this present clinical need, we're going to discuss OCT for intraoperative margin visualization. So by way of introduction, OCT is Optical Coherence Tomography. This is an optical technology for performing high-resolution cross-sectional imaging. OCT is similar to ultrasound imaging, except it uses light instead of sound. OCT can provide cross-sectional images of tissue structure down to 2 millimeters on the micron scale in real time, and that's reflected in this figure on the left. We see here various imaging modalities listed across the top. MRI, used to penetrate the entire body, has a resolution around 1 millimeter. If we move from high resolution CT to ultrasound to OCT, we see increasing resolution with less penetration. At the very end of our scale is confocal microscopy, which gives us the highest resolution. But OCT, which we're talking about here, can give us a very high resolution penetration down to 2 millimeters. That's also shown here in the figure on the right. You can see the H&E section in part A showing multiple levels of tissue. The OCT image of this same section is shown here in figure B. But when we look at it under ultrasound, resolution is much poorer. And you can see the advantage of OCT showing very high resolution near the surface. So we said OCT is similar to ultrasound. We see it here compared again when we look at the nail bed. You can see the area that's being imaged reflected here. This is OCT data. Compared to ultrasound data, you can see much higher resolution that we achieve with OCT. This figure shows very good anatomy of the nail structure, sterile matrix extending back into germinal matrix and the dorsal roof of the nail. This is the same anatomy shown with ultrasound. OCT has been around for quite some time. This figure shows a timeline. Back in the mid-90s, began widespread clinical use in ophthalmology. Later, in 2004, we see it move into cardiology, where this is adapted for catheter-based applications. Later, OCT was used in dermatology. Not long after, this has been adapted for endoscopy, and once again, we see broadened use of OCT in other fields. And now this is OCT surgical specimen device where we can use it to look at margins for solid tumor resection. This figure shows some of the other areas of application of OCT. Ophthalmology has been widely used OCT basically to look at the retina. You can see the advantage of this application. Once again, very high resolution looking at small tissue interface in a detailed fashion with enhanced diagnostic capability. Obviously, this translates pretty well into cardiology, where we want to do endoluminal imaging of plaques in coronary and other blood vessels. You can see here compared to histology. Very high resolution ability to look at tissue planes. This is also an example of OCT adapted to a device used to look at skin lesions. So now I'm going to talk about some of our recent clinical research that we've done in partnership with Perimeter Medical Imaging, looking at OCT imaging in breast tissue. This is a phase 1 pilot study done at Mount Sinai, New York, where we used a OCT imaging device to look at lumpectomy specimens from patients undergoing breast surgery. This was essentially a pathology-based study that was performed in the pathology lab immediately prior to tissue fixation. Pathology was linked to OCT image data for correlation. No diagnostic decisions were made in this study using OCT images at the time of the surgical procedure. Correlations were done postoperatively. In this first figure, you can see H&E sections on the top compared to corresponding OCT data on the bottom. The specimens were carefully marked so we could accomplish these correlations. Here you can see DCIS very close to the inked margin, and this is reflected in the OCT data. It was read as less than 1 millimeter or close margin for DCIS. In this part of the figure, you can see DCIS right at the inked margin, and this is also reflected in the OCT data below. If you look at a collection of the data from this phase 1 study, there were 50 patients and a total of 185 specimens, as many of these patients had cavity shave margins, which we also use for OCT analysis. The accuracy rate, when you consider all of these specimens, was 95.6% correlation between OCT and surgical pathology final report. We then extended this study for additional patients and moved the OCT imaging device into the operating room to explore its integration into operative workflow. Fresh images were acquired immediately following lumpectomy standard imaging using radiography. Workflow analysis was performed, but no diagnostic decisions, again, were made using OCT images during surgery. Correlations with histology were again done postoperatively. Here again, we can see a focal area of DCIS less than 2 millimeters from the inked margin. And this finding is also identified in OCT. You can see this honeycomb-like structure reflecting fat, an abnormal glandular structure here very close to the margin. In this figure, we see a radial scar reflected in the H&E. This complex area is also noted in the OCT data. These are some additional images of OCT breast specimens correlated to histopathology. Figure A, this is a cross-sectional view of the normal epithelium and lumen. You can see the dark center and very clear definition of the interface between epithelial layer. Next in part B is a longitudinal view of a normal duct. You can see this is imaged very well in OCT and correlates with this H&E image. Here we see a longitudinal duct extending into lobules, which are also evident on OCT data, and corresponding H&E section here. Here are additional images of normal anatomy. This again is a longitudinal view of a duct, which we can make out very clearly in OCT data. This is a cyst, which initially when you start reading OCT data can be confusing with ducts, but its uniformity and signal dropout in the middle, very characteristic of a cyst. Finally, here you can see multiple layers of blood vessel wall and the lumen, seen here on H&E as well. If we start to look again at DCIS and invasive ductal carcinoma in these figures, part A again shows us DCIS at this arrow in H&E, seen very clearly on OCT. And while the signal is reminiscent of ultrasound, this high resolution almost takes you down to the level of histology. Part B, also more DCIS. We can see those abnormal glandular structures here in the OCT data stack. This is an example of invasive ductal carcinoma here in part C. This densely packed tumor cells here cause massive signal dropout. That's reflected here in a characteristic pattern in the OCT data. Here we see further examples of suspicious ductal features in OCT correlated to histology. This is an abnormal glandular structure reflective of DCIS here, which highly correlates with the OCT data in this figure, right at the margin, essentially. Here again, we see abnormal glandular structures very close to the inked margin. We can see evidence of these structures as well in the OCT set. Now we're going to review a case from our phase 1 study. This is a patient with extensive DCIS, was high grade and extended larger than we anticipated, 5 centimeters, and there were multiple positive margins as well as close margins. You can see here the light image of our specimen with sutures marking. This is the specimen radiography from the Y localization that shows the clip in the center of the specimen. There's no obvious calcifications on the X-ray. When we looked at the H&E for this area, you can see extensive area of DCIS right up against the inked margin with multiple abnormal glandular structures. This patient came back for margin re-excision. If we look at some of the OCT data collected from this specimen, that's what you're seeing here. The bracket at the top in yellow is the area of interest, You can see that corresponds to these brackets in the light-based image. As we go through the data stack here, you can see abnormal glandular structures that we previously saw in the H&E reflected in this OCT data. One of the benefits of this technique is that the surgeon or the user can scroll back and forth through this data set at any given location in the specimen. So I'd like to thank everyone for attending the webinar today. I'm going to hand it off to Dr. Beth DuPree, who's going to talk to us about her experience with OCT in the operating room.
Good evening. I'd like to talk to you this evening about OCT imaging in the operating room. My name is Dr. Beth DuPree. I am the medical director of the oncology service line at Northern Arizona Healthcare. Having formerly been on the East Coast, I have relocated to Sedona, and I am very happy to be here tonight talking about a transformative technology. OCT imaging was FDA cleared in February of 2021. And if you don't know what OCT stands for, it's Optical Coherence Tomography. And as an early adopter of breast ultrasound, I have been really excited to use this technology because being able to see what is directly in the tissue in front of me without having to wait for pathologic correlation, and learning how to take this technology and correlate it with the final diagnosis pathology has been a very exciting journey for me. And we are currently in the midst of a FDA clearance, an IRB cleared protocol for using OCT in the operating room to evaluate a patient's tissue specimen. The device is small enough to easily fit in the operating room. The OCT imaging device is a freestanding device. We can move it from room to room. It has some really nice bells and whistles with it. The specimen immobilizer is actually where the magic happens. That's where the specimen is placed and the images are obtained. The screen in front of you right now shows the specimen on the imager. The circled blue area is the area that actually is scanned for evaluation. I am able to choose whether this is a primary or a shave margin, the amount of vacuum that I need to hold this tightly to the device. I then can orient the specimen to show which side is toward the glass, and the little green marker at the top shows which side is the other orienting side, so that we can be very, very clear about what we're imaging. Easy enough to start the scan. You push the button in the corner that says start scan, and the images are obtained. And this is a real-time placement of a specimen where I typically will break scrub. At this point, I'm very particular about how the specimen is oriented. I'm trying to get the best images possible. And I believe someday my nurse or a technician will be able to do this for me. But right now, I am being a little bit of a control freak because I want to know exactly what's going on. I choose the side toward the glass. I choose the orientation of my little marker, draw my area, and begin the scan. Placing the markers in, I choose to put silk sutures in the specimen before I even remove it from the patient. So as I'm dissecting the margins, the silk, I do a short silk superior, a long silk lateral, and that way, before I ink the specimen, which I will do after the fact, once all the imaging is done, I'm able to tell what's what. When I'm finishing the lumpectomy, I give the specimen with the silk sutures to my nurse and place it in the faxotron, get an image intraoperatively so I know that I have my markers so that I can look grossly to see if there's any calcifications near margin. And at that point, I am able to begin the scanning process. The scans are very, very high resolution. The area that I'm looking at is about a 2mm area. And what I'm actually looking for, particularly in the case that I'm going to show you, it's a case of pure DCIS. What this what this technology allows me to do is to have a real-time in the operating room assessment. I can scroll from margin to margin so that I can look through the images to try to identify areas of concern. This tells me which margin I'm looking at, and you can actually have the secondary picture so I can see areas of dense tissue, areas of fatty fibrous tissue, and the little blue marks in the lower left-hand corner are the areas that I have identified where I have found areas that I want to go back and take a closer look at. My timing for this in the operating room, when we did the initial study last year, it took me about 20 to 25 minutes. Now with the newer technology, I am able to do this in about 13 to 14, sometimes 15 minutes. And I really don't believe that this is a hindrance to what I do in the operating room, since I can have my assistant closing an incision while I am reviewing the images. So the blue boxes that you're seeing are when I find areas of concern, which these are areas of concern, and I'll kind of get into some of the images later. I'm able to go back and re-review those images. I know where, based on my specimen, if this is I believe this was the medial superior margin, I can go back and re-excise those areas of concern. That's a calcification there. And I can go back and then rescan the re-excised margin. This is a very interesting case, which I chose to share with you today because it really speaks to the power of this technology. It is a 71-year-old woman that presented with a 1.5 centimeter area pleomorphic calx, Ashkenazi Jewish heritage. She had a negative clinical breast exam. She had moderate macromastia with grade C ptosis. Her imaging showed one area of pleomorphic calcifications, which measured 1.5 centimeters. And one would think that she'd be kind of a chip shot lumpectomy, no big deal. I do get MRIs on these patients. You can see she has very dense fibroglandular tissue. Stereotactic biopsy proved this to be a grade 3 DCIS ERPR negative. She was very hesitant to have radiation. We did do a prelude DX on her, and it was low risk. Her multi-site 3 came back negative. And her, as I said, she had grade C ptosis with moderate macromastia. We were very surprised when I got her MRI and found almost a 7 centimeter area of enhancement. It was localized to the upper central portion of her left breast. And I spoke to the patient about all of her options. Because of her significant ptosis, she absolutely was not a candidate for a straightforward inframammary nipple sparing mastectomy. She really wanted to preserve her breast. And what we gave her the option of was a reduction pattern lumpectomy with preoperative RFID localization, because I obviously can't see this area on the mammogram. There were no calcifications except for that one small 1.5 centimeter cluster. And years ago, before we were doing nipple sparing mastectomies on breast reduction patients, I would have been hesitant to do this, but I had the forward-thinking game plan that if we fail to get negative margins, we then have the next step, which could be a nipple-sparing mastectomy. So the MRI showed almost a 7 centimeter area of the non-mass-like enhancement. We chose to offer her participation in our IRB-approved trial utilizing the OCT to help me determine intraoperative management. And she was well aware from the beginning. And we did present her at our multidisciplinary NAPBC accredited tumor board. Everybody was on board, and the patient was very happy with this plan. So she underwent MRI guided RFID localization of the areas of enhancement. You can see the stereotactic marker was near the calcifications, but the area of enhancement, you can see much more clearly delineated by the RFIDs. And the my breast imaging radiologist did place those under MRI guidance. Patient underwent ultrasound and RFID guided lumpectomy. You can see that the specimen was actually turned a little bit on its side. It rolled over. So these really were not, the RFIDs were not as close to the margin as they appear in this x-ray. My OCT from the additional margin was positive, so I went back and did an additional medial margin. Still saw this dilated duct, which is indicated by the red arrow. Went back to get an additional true medial margin, and each of these margins was a centimeter of tissue. So my first specimen was a large, approximately, I believe, a 200-gram lumpectomy. It was the entire upper central portion of the breast. So each additional margin was another centimeter of tissue. So this second centimeter of tissue, clearly I could see that there was this abnormal duct. And at that point, the plastic surgeon was like, well, how much more tissue are you going to take out? And at this point, I was very concerned that she was going to still have a positive margin, but I knew that if I went any farther, I was going to be impacting his ability to maintain the viability of her nipple. Dr. Pepez, my pathologist, then gave me confirmation with true verification several days later that the DCIS wasn't just one solitary duct. He called it broadly positive, which meant that you can see multiple ducts are filled with DCIS, and my true margin was still too close. And at the end, she had on her initial specimen 4.5 centimeters of DCIS. She did have a sentinel node biopsy done because this was high grade and more than 4 centimeters based on our clinical and radiologic knowledge. The DCIS was called broadly present within less than 0.1 centimeters of the medial margin. Again, in the second 1 centimeter specimen, still present. In the third, it was still present. So what I've been able to do with knowing with this technology after surgery, I told her, I really didn't think I was going to be able, that we would have a negative margin. I did not think I could go back and re-excise any more tissue and still have her maintain an adequate cosmetic result. And now she will wait 12 weeks and we'll do her nipple sparing mastectomies. But I was able to save her a second operation because if I had only done the initial lumpectomy, I would have taken her back for a re-excision and that margin still would have been positive. So with no calcifications at the edge of the specimen radiograph as my only current usable intraoperative assessment, had I not had the OCT, she would not have been able to potentially avoid a third operation. And she's very happy with this. She was very happy. She participated in the trial. And this just speaks to the utility of OCT intraoperatively. And it doesn't behoove me to show you the cases where I've had negative imaging and negative margins because there's really nothing to show, except that I was able to utilize this technology and allow patients to have re-excisions intraoperatively and save a second operation. Thank you everybody for your time and attention, and I will be around to answer any questions. And now I'd like to pass the baton to Dr. Thompson so he can present his data.
Thank you very much for this opportunity to demonstrate to you some of the thoughts behind AI and OCT specimen imaging. My name's Alastair Thompson. It's my privilege and pleasure to be associated with this project. And just by way of what I'm hoping we're going to cover over the next few minutes, I'd like us to just contemplate what artificial intelligence is, to think about AI in breast cancer care, to look at the project that's ongoing, constructing an atlas that's of relevance to the OCT imaging proposal for a clinical trial that we hope will be opening very shortly across the United States. So you probably know all these thoughts about artificial intelligence. And as the Venn diagram on the right-hand side shows you, that artificial intelligence comprises a whole lot of task performances that can be integrated and actually usually require not just artificial, but also human intelligence. As a subset of that, there's something called machine learning, which uses training algorithms to solve pattern recognition. And instead of specifically programming them, it basically works out how to solve a particular task. And then there's deep learning, which uses training algorithms, often referred to as deep neural networks with multiple layers, much more perhaps like the human brain would work. So how about AI in healthcare? Well, we already take this for granted a lot of the time. As you can see, as this slide illustrates, we use imaging and pathology, and with the support of AI, that's integrated and automated in some ways behind the scenes so that the volumes of information and the complexity of data we have can be handled and move us from clinical information through to making clinical decisions. You're probably familiar with this very basic slide relaying the concept of a biological neural network. We've previously learned what a cat looks like. And then when we see a cat once again, there's a pattern recognition that goes on with the neural network, which says, this is a cat. So speaking of cat scanning, if you look at this CAT scan of the brain on the left-hand side, lots of different images, you can see that a computerized neural network, convolutional neural network, if you will integrate all those pieces of information. And having learned and being able to work similarly to the human brain, as I've just shown you, can give us an output of, is this infarction, is this hemorrhage, or is this a tumor? So that's all very well for background, but let's think about AI in breast imaging. Many of you will recognize on the left-hand side of these two pictures that it's tricky to pinpoint the tumor, and indeed only 7 out of 14 radiologists were able to identify that tumor to begin with. But as the right-hand picture with the artificial intelligence enhanced breast imaging shows you, once you apply AI, every radiologist, in fact, all of us, can clearly see correctly where the tumor is. And this is a good example of how well AI can enhance breast imaging. I apologize somewhat for the busyness of this slide, but let me walk you through this study from 2020, if I may. As you can see, it's looking at the impact of AI in breast imaging. And on the left-hand side, you can see the different panels, the general and the specialist reading panels, looking at the sensitivity, and below the specificity. The first column of numbers tells you how well artificial intelligence performed. And you can see that without exception, AI was actually better than the radiologists. And you can see the radiologists in that second column of digits. Now, what's pertinent to our way of thinking and how we're going to get some important strides forwards with image assist is that if you combine the radiologist view with the AI, you can see in that third column of digits that in every single instance, in each group, there's an enhancement of performance. And indeed, the sensitivity when you employ AI with radiology goes up by about 13.5%, and the specificity is improved by about 10%. So that's the take-home message from this complex slide, that AI in breast imaging actually can enhance what a radiologist will find. What about breast pathology? Well, we're all very familiar with how difficult it can be to work out how many mitoses there are and how mitoses underpin grade, and grade is very important in the breast cancer world. You can see here that there's a training and validation process that's gone on top right to allow on an individual basis a cell to be classed as showing mitosis or being a normal cell. And then in the third, step 3, panel bottom right, you can see that 24 readers, 12 residents, 6 fellows, 6 faculty members were entered into this study, where group A, the left-hand side, the mitosis detection was employed using AI first, and then after a washout period, so that they'd forgotten what they'd said about each slide, the mitosis detection was then re-evaluated, but without AI. And then group B, it was the other way around. First of all, using just the imaging and the pathologist to detect mitoses, and then after a washout period, to look at the detection of mitoses with the assistance and support of AI. In this first of 2 slides, you can see that the accuracy by experience level was perhaps, as you might expect, that as the users, the PG2 through PG4, got more experience, and as the fellows who were perhaps at the pinnacle of their achievement performed even better than the faculty, without AI support, they did actually much better in every case with artificial intelligence to support them. And that improved accuracy with AI support was actually significant from a statistical point of view, as you can see on the far right of this screen, for every single group. Now, if you then consider the time it was taking for these pathologists to count the mitoses and the relationship to participant experience, by and large, it didn't matter what level of experience you had, you did better, quicker with the AI support. And you can see that particularly even for faculty who are experienced, and astonishingly for fellows who were taking quite a long time, that really crushed the time it was taking to get to a conclusion. Real triumph for AI. So how does this relate to what we're talking about today, the developments of artificial intelligence in breast surgery? And this is where I do have to point to your disclaimer, which you're very willing and able, I'm sure, to read for yourselves, that Image Assist is not currently available for sale in the United States. What I'm going to do very briefly is talk about how artificial intelligence is enhancing our ability to spot potential positive margins in the setting of breast conservation surgery. So I wanted to thank Perimeter Medical, who went to the trouble of convincing the Cancer Prevention and Research Institute of Texas to support this really quite substantive project employing optical coherence tomography and machine learning to help us do better with getting to the heart of who have we got a successful lumpectomy on, or who has a positive margin. And you can see that the project is in partnership with a number of academic institutions, including my own Baylor College of Medicine. So in terms of capturing the data, you can see on the left-hand side that the optical coherence tomography images are being captured in the pathology suite immediately after surgery across the 4 sites. It takes a little bit of time to generate the pathology report, second picture in, but then that pathology report is cross-integrated with an expert analysis of the OCT images to make sure that we can label where the images are showing things versus the actual pathology report. And this is true for both those patients who the lumpectomy has had positive margins and those patients for whom there have been negative margins. And then finally, as you can see on the right-hand side, an expert pathologist trained in OCT interpretation will then compare and label the OCT images. Now, where is this going? Well, just as you've been hearing about the training and the testing of whether it's a CAT that we're recognizing or whether it's a CAT scan that we're looking at, you can see that the label data that's fed into the optical coherence tomography machine learning model will then give an output saying, don't like this, it's suspicious, or actually it's acceptable, it's normal. And you can see on the left-hand side of this picture, the neural network architecture that feeds into that decision of suspicious or normal. On the right-hand side, this is actually how things look. And it's a really quite nice, very detailed look at the images that you can get. And this will be working intraoperatively, as we'll come to in the video at the end. The plan is to test this out with a multi-reader, multi-surgeon, multi-center study to determine the accuracy of surgeons, readers, and the artificial intelligence identifying individual areas, individual spots, if you will, that could be positive margins. And so here is the pivotal trial that's going to be rolled out across the United States. I just wanted to point out that this is going to be at academic and community centers, that it's going to be, yes, happening in Texas, but actually at sites throughout the country, a great diversity of people that will be served by this trial. And I think it's going to give us a very good idea of just how good optical coherence tomography imaging is with the AI, the artificial intelligence image assist, on identifying positive margin rates in breast conservation therapy. So with that, I would like to conclude and thank you for listening. Perhaps we're going to now see something to a video of the image assist, which I can talk you through. So here's an example of the sort of pictures that one will see with image assist and the optical coherence tomography. At the top, you can see the scan, the OCT. Bottom left, you can see, and also bottom right, the picture of the specimen that's been taken. And then in the middle, being highlighted just now, that's the sort of image that's being taken by the optical coherence tomography. Now it's scanned across and it's found various thumbnails, highlighting in red just now the thumbnails that are considered to be suspicious, the ones in blue less so. And now you can see the arrow is just pointing to some little target type lesions, which are very suspicious of Dcis being at the margin. Where does that relate to the main specimen? You can see the little red dots just being highlighted there. And you can see how that allows you then looking at the middle bottom image with the top image with the red bars pointing to the little targetoid images, as you can just see there, that actually represent ducts full of Dcis that are right on the margin within the 2 millimeters, highlighted just there. Absolutely, yeah. Okay, and you can see that by comparing what's at the top, beautiful targets there, you can see that the Dcis really is at the margin. And it's on a number of these thumbnails. And now that we're scanning across, you can see it's really a number of places quite close to each other on that main specimen. And as we scan up, you can see that we're looking across more and more of this image. It's actually quite normal just here. There are none of these little red bars to highlight things. And in the middle picture below, you can see that the scan has gone up towards the top, then heading down a little bit further. But you can see that all these little red bars that are picking up an area quite localized in this specimen and related to the main specimen visually, you can see where that would be. Very helpful in terms of going back to take an additional margin. So thank you for looking at this example of optical coherence tomography and the artificial intelligence highlighting the regions that we need to look at. We're going to stop there and thank you for watching. Thank you for listening and be very keen to hear your responses and any questions you have. Thank you very much for your attention.
Thank you very much, Dr. Thompson and Dr. DuPree for outstanding presentations this evening. We're going to take a few moments before we end to answer some questions from our audience. Do we have the first question? Right, so this one came up a few times. Will OCT be used in addition to specimen X-ray in the OR? I think we all recognize the importance of using specimen radiography to ensure that we achieved our target in the form of documenting that the clip has been removed. And so I think this will definitely be a companion. Both techniques will be used together.
I completely agree with that. Today, I had a case of pure DCIS where my radiographic clip was close to my inferior margin, as were the calcifications. So even before I imaged, I knew that even if I didn't have OCT in the operating room, I was taking an additional shave margin, which I did. It was negative, so I didn't even image that margin until after I had done the shave, because I knew that my marker was way too close to the margin, as well as the calcification. So this is about using everything that we have. We have the pathology, so we know whether it's DCIS, high grade, multifocal. We've got the MRI images. And then you have what you use in the operating room. And I typically do ultrasound localizations unless I'm bracketing calcifications where I use the RFIDs. But today I was able to image that area, know that my inferior margin was good, and go to the areas of concern where I found a the duct almost jumped off the screen at me heading up toward the nipple. So I knew that I would have to do an additional margin there. So it's about using every piece of information that we have, because OCT isn't going to image a mamma marker or a hydro mark. You're not going to see that because you're only looking at that 2 millimeter rim around the tissue. So I completely agree with you, Hank. I think that this is about using every piece of information that we have to do what's best for the patients.
Yeah, I completely agree with you, Beth and Hank. We're unanimous.
Should we go on to the next? Can you use this technology on additional shaved margins? I would say definitely yes. This made up a significant portion of the data from our both phase 1 and phase 2 study. It's much easier because you don't have to reposition the specimen. You're only really interested in one side. Also, a much smaller amount of data to look through. But I would say very useful, just as much so as on the primary lumpectomy specimen.
Agree.
Yeah, I'd agree with that. And maybe the thing just to recognize is that the margin you want to image is the new margin, and that's what needs to go face down on the scanning surface. And that takes a little bit of thought, but it gives you a very clear view of your true margin, if you like.
When we first started doing this study, I had to, I just was really clear with my scrub tech that if I lay a specimen down with an instrument attached to it, I did that purposefully so that I know exactly what I'm doing, because I have to go back and check the cavity before I leave the field. And it's kind of funny because I know exactly which way that needs to be positioned three-dimensionally. So now there's like the no touch zone on the Mayo stand, where if it is in the no touch zone, you're not going to want to touch anything there because there will be repercussions on my side. Yeah.
Maybe the other subtlety to just mention is if you're one of the people, as I am, who tends to use a suture just to mark that true margin, that suture can be seen with OCT and can be distinguished very readily, very easily from the sort of things that we're really wanting to catch, like DCIS.
Absolutely, fantastic. Do we have one more question? What does the clinical data for patients treated with neoadjuvant therapy look like for this technology? Dr. DuPree, have you used the OCT device on patients having breast-conserving treatment after neoadjuvant treatment?
I have not used it yet because it's one of the things that fell outside of our clinical parameters, but I think it's going to be a wonderful utility now that it's FDA cleared. It's something that, for me, a lot of times I can see the patients had a complete clinical response to neoadjuvant chemo based on the size of the invasive cancer, but we all know that the DCIS is it's the part that haunts us forever, because much DCIS is not going to go away with neoadjuvant chemo. So it's one of the things that it doesn't fit the parameters of my clinical trial, but now that it's FDA cleared and I happen to have an OCT device in my operating room and all of the disposables, it's something that I absolutely want to look at, not from a clinical trial perspective, but it's a really big deal, because for these patients, we're really trying to preserve their breast. And it's not the invasive cancer typically after neoadjuvant chemo that's going to give us a positive margin. It's going to be the DCIS. So it's something that is absolutely on my radar screen, because no one dies of breast cancer of the breast. You die if breast cancer spreads elsewhere. So if we can prove that they have a negative margin intraoperatively, we can at least give that patient an excellent cosmesis and a chance at local cure.
Yeah, Hank and Beth, perhaps I could just mention that one of the things we're all aware of is that neoadjuvant therapy, but particularly neoadjuvant chemotherapy, is increasingly used for even quite small 2-3 centimeters cancers to try and downsize them. And as we know that sometimes you get a complete pathological response, complete for the HER2 positives and some triple negatives. But if there is residual disease, as you were just saying a moment or two ago, it's often the DCIS that's left behind, and sometimes that DCIS may be beyond where you'd expect. So the ability to pick up that DCIS that has been left behind after the neoadjuvant therapy, the neoadjuvant chemotherapy particularly, I think is a very valuable tool in reassuring our patients that local recurrence in the breast conservation, the lumpectomy site, is going to be minimized, because if we find the DCIS at the margin after neoadjuvant therapy, we can do something about it intraoperatively.
Absolutely. Another question that I'm going to ask, and maybe Dr. Thompson, you can address this. You alluded to the pivotal upcoming multi-center trial. I'm just curious if you could comment on the design of that trial and maybe speak to any requirements in the protocol for credentialing surgeons, or what the requirements would be in those areas.
Yes, these are fine details in terms of being important details. But in essence, what we're trying to do is do a randomized trial where the randomization is between using optical coherence tomography versus not using it. And with randomizing patients so that patient is either subjected to this wonderful tool or conventional way of doing the lumpectomy and not looking with OCT, I think is going to give us the best evidence as to just how this way of thinking, this new way of thinking, if you like, intraoperative assessment with OCT is going to change practice and make for, I hope, FDA approval for getting this instrumentation into as many operating rooms as people are willing to try it out in. Some of the other nuances are that this is not a simple pick up the machine and switch it on and it'll all work. You think back to those of us who have been using ultrasound, for example. We don't simply pick up the ultrasound probe and instantly we know what we're looking at, and it's all terribly easy. It's not quite as straightforward as that. There is a comprehensive training to be able to get involved in this trial, and I think that's right, because we want to make sure that we test the equipment properly and that human error is removed. So making sure that the participants in the randomized trial, and by that I mean the surgeons getting involved, are well trained, are well versed, and know what they're looking at, is just as when we all started out with ultrasound, for example, is really important.
Alastair, I want to echo exactly what you said, because my re-excision rate was already low before I started using OCT. And I think that was one of the reasons why, besides the fact I live in a beautiful area of Sedona, Arizona, and the reps probably wanted to come here. I mean, that in and of itself was a reason to be a great center to come to. But I used ultrasound. When I started using ultrasound back in 2000, and I bought the first ultrasound I had in my office, my husband ran my practice at the time, and he said, "You're not going to get reimbursed for ultrasound." And I said, "The ultrasound is the extension of my fingers. I can't feel as the ultrasound can show me what's happening." And when I incorporated ultrasound into my practice, I recognized that, we do a disservice in breast care if our young fellows coming out of fellowship don't understand the utility of ultrasound, the importance of it, to look at the lymph nodes, to look at the distance from the tumor from the pectoral fascia, to look at the distance from the skin, to truly have an extension of your fingers. When I first saw OCT and I saw the clarity of the image, and I'll be honest with you, and it's kind of like if you do something for the first time and you see something and it jumps out at you, you may, my very first case that I did was a patient that traveled 3 hours from me for DCIS. That was a tiny little 4 millimeter area of calcifications on her specimen, a very dense breast. When I imaged this patient, literally on the first margin that I looked at, and this was at the time where I was not using it to go back and re-excise, I saw that duct within 30 seconds of scanning through the specimen. And I said, "Oh my God, if that's DCIS at the margin, I'm sold," because I know that I can train myself and I can have the fortitude to look at these images and to be able to take that, what I know about imaging, and then when we can eventually add the AI to it, you're going to be able to expand the number of people that will do this. But right now, I really think that in this trial, to use surgeons who are already very, very high acuity of breast ultrasound skills is going to be key, because as we go through this process, we want to be successful in moving forward. and it is a transformative technology. I will tell you, I hate it when I see a positive, when I see a giant duct on an image, but I also get back to that place and say, that would have been that phone call from the pathologist 3 days from now to tell me that I have to go back and re-excise that medial margin, instead of being able to go in and, like I did today, core out the papilla, which is where the margin was, right at my suture, right at the nipple, knowing that this lady with DCIS, who is very resistant to radiation therapy, today's case would be the difference between a lumpectomy or a mastectomy for her. And that is where, that's why I'm part of this trial, because I believe that the difference that we make in the operating room is a huge difference. And anyone that ever calls the patients to tell them they have cancer recognizes that the second worst phone call is, Mrs. Smith, your margin's positive, we have to go back. Or Mrs. Smith, your margin's positive, you need a mastectomy. So for us to be able to have the opportunity to work on the cutting edge of transformative technology like this, I think is amazing.
Yeah, I completely agree with you. And maybe just to sum up my individual personal thinking about this, is that this is not just transformative, but it's also disruptive, in that it's a technology that's going to prevent us having to go back on occasions to do re-excisions, which all of us hate, and our patients loathe it as well. And from that point of view of just getting it right first time, I think that's a mantra that we would all subscribe to, but we don't always, including myself, manage to achieve. So with this sort of technology upping our game, if you like, I think it's going to be really good in the future.
Certainly incredibly valuable to our patients. So I think we'll leave it there. It was a pleasure getting insights from both Dr. Thompson, Dr. DuPree tonight. Thanks very much. And thank you to all the attendees. Have a good evening.
Thank you. Good night.
Good night.